Hello everyone, and welcome to this lab talk. Today I am delighted to present Dr. Shuko Harada and Dr. Aakash Desai, both from the O'Neill Comprehensive Cancer Center at the University of Alabama at Birmingham. Dr. Harada and Dr. Desai will be presenting Revolutionizing Solid Tumor Management, Unleashing the Potential for Liquid Biopsy. So just by way of agenda, I will start with a brief introduction to diaceutics, as well as our precision medicine platform, DXRX. I will then hand the floor to Dr. Harada, who will present liquid biopsy from a pathology perspective, and it will outline the need for genomic testing for cancer, tissue versus liquid biopsy, and also technical aspects of liquid genomic profiling. We will then move on to Dr. Desai's presentation, which will provide an oncology perspective for liquid biopsy, and it will include genomic testing and its role in targeted therapy, as well as applications of liquid biopsy and liquid biopsy in the clinic. Finally, we'll dedicate some time at the end to answering a few questions. Questions are welcomed, and you can do this by typing your question into the Q&A box on the right side of your screen. Feel free to add questions throughout the presentation as and when they come to mind. So to begin, Diaceutics is a consulting and data analytics company specialized in precision medicine. We are committed to a goal that can be summarized in our motto, better testing, better treatment. We are striving for a future where all patients can receive appropriate treatment as soon as possible. We have experience in 96 different disease pathways and have worked on many different precision medicine drugs brought to market with the world's most prominent pharmaceutical companies. We are a global team of experts spread over 53 countries. So with this aim in mind, we have built DXRX, an online platform conceived as a digital gateway that provides a space for all precision medicine stakeholders to collaborate with one another, as well as take advantage of our data insights. Laboratories, pharmaceutical companies, scientific societies, and diagnostic companies can all find benefits from being registered users on DXRX, and we expect these collaborations to have a positive impact on patients. So we especially built DXRX to place laboratories at the center of the precision medicine ecosystem, as driving precision therapies would not be possible without their work. So here are some of the services we offer to labs through DXRX. We have DXRX collaboration opportunities for labs and other stakeholders to work together and participate in intercomparative ring studies or other scientific programs, as well as getting access to grants and sponsorships. Labs can also increase their visibility to other precision medicine stakeholders, such as pharma and diagnostic companies. And DXRX allows access to educational resources, such as lab talks, webinars, biomarker reports, newsletters, and also access to aggregated data. So DXRX is conceived as something that the lab can benefit from, and as such, membership is free of charge. If you are interested in the lab offerings of DXRX and would like to know more, please reach out to us or register directly on our site at dxrx.io. So now that you've had a brief overview of DXRX, it's my pleasure to introduce Dr. Harada and Dr. Desai. Dr. Harada is a tenured professor at the Department of Pathology at UAB. She has been leading the molecular diagnostic lab, expanding the oncology and infectious disease molecular test menu, which built a fundamental ground for cutting-edge joint venture, the Genomics Diagnostic Laboratory. Dr. Harada also serves as a program director for UAB's Molecular Genetic Pathology Fellowship and mentors fellows and junior faculty members. Dr. Harada has published over 85 peer-reviewed manuscripts, 41 of them as first or corresponding author, with 34 of them published since 2020. She has been participating in leadership roles at the national level for several professional societies, including APC, NCCN, ASCP, and AMP, to name a few. Dr. Desai serves as an esteemed assistant professor of medicine at the O'Neill Cancer Center, UAB. He holds a particular interest in thoracic oncology, phase 1 clinical trials, and utilizing liquid biopsy and its applications. Dr. Desai embarked on his medical journey at BJ Medical College in Ahmedabad, India. His journey of specialization continued in 2020 at the globally recognized Mayo Clinic in Rochester, where he joined the fellowship program in oncology and hematology. Dr. Desai has over 100 peer-reviewed publications and has leadership roles in several national societies, including the NCCN, ASCO, and the International Association for the Study of Lung Cancer. We are thrilled to have you both with us today. Dr. Harada, the floor is yours.
Thank you, Yaris. I hope you hear okay. So I'm going to talk about pathology perspective on the liquid biopsies. And the outline is here. As Yaris said, just going to talk a little basics background about personalized medicine, and then talk more about technical aspect of the liquid biopsy. So personalized medicine or precision medicine is a concept that information about the patient genotype or gene expression profile to be used to tailor medical care to an individual needs. So precision oncology, it's like cancer patient who at the same location having a genetic profile, finding a different driver gene mutation, so then you can treat based on that driver gene mutation or change that is meant as a, that is also said as a, described as targeted therapy. So the example of lung cancer, non-small cell lung cancer, especially an adenocarcinoma, showing in the top right chart, there's a lot of different molecular driver gene mutations, including EGFR, KRAS, ALK, ROS1. So there's more than half, majority of them has those very driver genes mutation, and then the majority of them have the targeted therapy for that. Those the early acceptors, early developers, EGFR, ALK, BRAF, ROS1, and immunotherapy for the PD-L1 expression. And then, of course, red MET, HER2, and so on. There's more targets available for the treatment. So you'll see in initial early time, lung cancer biomarker recommendation had only few genes, KRAS, EGFR, and ALK ROS1. But in 2018, the guideline changed to additional targets, including BRAF, HER2, MET, RET, and also NTRK for now. So if you're having these many targets, next generation sequencing to get multiple genes at once instead of one by one makes more sense and efficient, especially the cost of the sequencing coming down significantly, showing in the left side. So you're gonna test on a tissue for those. It's great if you have the resection specimen or the big tissue on, like seeing a paraffin block in here. We get DNA and RNA from here. And even a core biopsy, it's if you have the majority of the core in the tumor, it still be okay to be able to test it. But a lot of time, especially in advanced cancer patients, we only have fine needle aspiration or small, very tiny core biopsies, which only have maybe less than 100 of tumor cells. Like showing here, purple is showing us tumor cells, but it's so widely spread out, there's not many. So then you cannot really test on the tumor cells. Then where the liquid biopsy comes handy. Liquid biopsy, well, any liquid, including blood, CSF, pleural fluid, but in this case, we refer as blood testing. And blood has, of course, white cells, red cells, and platelets. But if you remove those cell components, and then there's a plasma, which includes the floating cell-free DNAs and RNAs, in addition to the circulating tumor cells in some time. So in bloodstream, tumors shedding DNAs because the necrotic or apoptotic dead cells kind of fragmented and then degraded, and then those DNAs shedded into the bloodstream. Those are the ones called circulating tumor DNA, ctDNA, as shown in here in the middle. So if you get a blood from the patient, you can test those ctDNA for sometimes maybe the early detection or surveillance for the monitoring for the therapy effect, or maybe the early detection of relapse. So what is difference between tissue biopsy and liquid biopsy? Of course, tissue biopsy stick the needle to the tumor cells on the showing the left, and then liquid biopsy is drawing the blood from the patient, and that has some tumor DNA floating in it. So obviously, tissue biopsy is more invasive. You need to go through, especially like if it's lung, you have to go through invasive procedures. And compared to that, liquid biopsy is very just blood draw. And so it's easy to monitor many times. You can draw many times. You cannot really do biopsy many times as the treatment going on. And another thing is some believes tumor is not homogeneous. There are some heterogeneity. Some area has different mutations to others. So the tissue biopsy only get very tiny portion or part of the tumor. So it may not be representative for the entire tumors. Whereas liquid biopsy is, they believe it's more representative for entire tumor, even heterogeneity. And both of them have some weakness for the tumor cells on the paraffin block is cross-linked DNA, and it's not the best quality. Whereas another weakness for the liquid biopsy side, it's sample handling. I'm going to discuss a little in a minute, is important because it gets degraded easily or contaminated by genomic DNA easily. So overall, liquid biopsy is thought to have higher false positive and negative rate, and tissue biopsy is still preferred sample and the gold standard. But it's not always available. So we could use liquid biopsy. Now, gradually accepted a liquid biopsy can be used for the biomarker testing and targeted therapy choice option decisions. So this year, recently, Association for Molecular Pathology and College of American Pathologists published in online right now for the recommendation for the cell-free assay and validation, because there are so many variables in testing. So first, pre-analytical, the sample collection, it is very important to know that cell-free DNA in general degrade very rapidly. So if you leave it there for a long time, it's just gone. Also, genomic DNA is 1,000 times abundant in the blood sample. So if you have the little bit lysis from the red, not red cells, white blood cells, and there will be diluted significantly the tumor cells, so tumor DNA. So that's very important, that how to collect the samples collected in the EDTA tube or the cell stabilization tube. Those two are the most commonly used. And storage temperature, you don't want to leave in a warm temperature, and or time before the process. Process means spinning as the first step, and typically two-step spin is preferred to minimize the genomic DNA contamination. And plasma is the typically preferred sample rather than serum. And DNA input is also important, so that because you know that you want to detect more molecules from two ctDNAs. So typically, it's recommended 4 to 10 mils of blood, or about 2 mLs of plasma or more. And interesting, well, extraction methodology is variable, and there's no recommendation at this point in that publication. So, and then now goes to how to detect the cell-free DNA or circulating tumor DNA. So how many genes tested? There's a variability from single gene to over 500 genes. And some of them are testing personalized gene target, like some commercially available. And then methodology is also variable. There's a allele-specific PCR or ARMS, which is a very specifically just pick up 1 or 2 targets, which was commercially available in the early days by Roche Cobas or QIAGEN TerraScreen. And those are only few targets, and now, and they're not really sensitive. So there's a very sensitive methodology, the droplet digital PCR or beaming PCR, and or next generation sequencing based. So if you look at this graph showing top is a higher sensitivity, and there's a difference in the assay. So in general, the Cobas or TerraScreen, that's so commercially available methodology, is about sensitivity of 1% or a little bit less, maybe down to 0.5%. Whereas the digital droplet PCR or beaming assay have much higher sensitivity, like lower than 0.1%. Now the next generation sequencing, it's showing here in the middle, like 1% or higher. But of course, all depends on how deep you sequence. I'll talk a little bit more detail in a minute. But then because if you sequence more, you get higher sensitivity. So there are some next-gen sequencing-based assays approved by the FDA, commercially available. So beaming is one of the digital PCR technology, which has a beads attached to your target primers and mixed with plasma, and beads binds plasma DNA, cell-free DNA binds to the beads and then amplify there, and then put some fluorescent tag, which was measured by the laser by magnetic flow sorter, similar to flow cytometry. And more widely used tech methodology is droplet digital PCR. ddPCR makes a very samples are partitioned into the little droplet, showing that here on the left bottom. And then in the droplet, it amplified the target by PCR. And then that, of course, the PCR target has fluorescent tagged, so that would be measured and then calculated. So this is the kind of most sensitive assay to detect low abundance of tumor cell DNA. And if you go to talk about next generation sequencing based assay, you just need to talk a little bit what is NGS. It's just think massively parallel sequencing. If you think first about sequencing by traditional method, Sanger sequencing, entire genome, you have to have a primer set to each tube on each exon. And then number of the exon, let's say 5 exons in one gene, you have to have that many tubes. And then you have number of genes you want to test, 50 genes, you have to have multiple 50 genes. So there are a lot of tubes needed. So next-gen sequencing can be done everything in the parallel, in one reaction. So the DNA is fragmented and then added adapter and barcoding. That's the key. And then those are amplified either in a droplet or a solid phase, and then sequence them separate together. But then each of them has a barcoded, so you can distinguish which one coming from where. And then there's multiple millions of sequence reads of small fragments out there. And then those will be aligned based on against the reference genome sequence. So there, you need a bioinformatics pipeline. You cannot do by hand by one. So bioinformatics pipeline align them against the reference genome sequence. And then how many sequence reads are in there in a particular region, that's the depth of coverage. When you have 10 reads on one region, it's 10x coverage. And then if you have the variants, 3 variants in a 10 sequence reads, which means 3 out of 10 have variants. So that is VAF of 30%, variant allele fraction. That is important to know when you talk about NGS. So sensitivity of NGS testing really depends on average read depth. If you only have a 10x coverage, you can only detect 10% allelic fraction variance. So the sensitivity is 10%. If you want to cover 0.1%, if you have 1,000x reads, you only have 1 read, then that's 0.1%. That's why most of the assays have 1,000 to 5,000 or even greater than 10,000 on showing the right side of the bar graph, so needed. So digital droplet PCR, on the other hand, has 0.0015 to 0.25%. Mean average sensitivity is 0.09%, which is pretty good. So since the larger sequences are available and now the sequencing cost is getting cheaper, we can go 500 gene with tumor mutation burden or MSI included. It's with 1,000 or maybe 5,000x coverage to increase the sensitivity as well as the capturing the capability. It really needed that many genes. That's a debatable question, but the world is going that direction right now. It's getting more robust sequencing becomes available. So those are to increase the sensitivity. Now there's another distractors for the liquid biopsy causing potential false positive. This is the distractors on chips and chip and germline variants. Chip is clonal hematopoiesis of indeterminate potential, which is acquired mutation in hematopoietic stem cells. Doesn't necessarily have a cancer. It's getting more frequently seen in the elderly patient. When you age over 70, you may have seen those chip in 10% of the healthy patient, healthy population. The commonly seen genes, including TP53. TP53 may be a tumor cells mutation or this chip. So this is you need to be very careful. This could be a potential source of the false positive. And germline variant is also tricky because germline variant means you have inherited variants. It's always there. Typically, germline variants, BAF variant allelic fraction is greater than 40%, either 50 or 100%, depends on heterozygous versus homozygous. But sometimes, and then somatic variants coming from tumor cells is much lower, especially in the blood. But sometimes somatic variant could be represented high fraction, especially when you have the high load of circulating tumor DNA or amplification is present in the tumor cells. So there's recently, like this year, the people started thinking we need to have matched white blood cell sequencing to subtract those germline variants or chip information. And that may be coming in the future. So clinically, with all these pros and cons, weaknesses, but still there's a utility, definitely. In this case scenario, patient has a lung cancer treated by EGF receptor tyrosine kinase inhibitors, yet it's progressed disease. So then we have the liquid biopsy and then detected a resistant mutation, T790M. And in this case, they did also subsequently tissue biopsy, but even without that, you can switch the therapeutic agent to that third generation TKI, and then that's clinically significantly improved. So there's a lot of potentials in the liquid biopsy. So my last part summarizing here, liquid biopsy, especially circulating tumor DNA testing, has been increasing significantly and expected to increase furthermore for disease monitoring. Pre-analytical components of how to handle the sampling is critically important. And there are various test platforms available. Droplet digital PCR and NGS are the most commonly used, but each assay has pros and cons and different assay performance. So it's very important to understand the limitation of each assay. And then standardization of assay as well as reporting yet to be needed to further advance or utilize this assay. So with that, I'll pass over to the Dr. Desai.
Thank you so much, Dr. Harada. I think that was an excellent presentation. I learned a lot about the pathology perspective of liquid biopsy and what happens in the lab. And so I'm going to continue this sort of trying to discuss more about how circulating tumor DNA, liquid biopsy is being translated to bedside, really, when we think about bench to bedside in precision oncology. So the outline of my talk, I'm going to be talking a little bit about genomic testing and role in targeted therapy, sort of borrowing and continuing what Dr. Harada was talking about. We will talk about applications of liquid biopsy in the clinic, both in advanced or metastatic disease, as well as in early stage disease, early stage cancers. And then also touch upon the emerging role in cancer screening, risk stratification, and surveillance, as well as sort of end with an example of liquid biopsy in action in clinic. So when we talk about targeted therapy in cancer, and as Dr. Harada pointed out earlier, with the whole boom of precision oncology, it makes a lot of sense, because if you look at this figure on your left, which sort of talks about the hallmarks of cancer and different properties that cancer cells or tumors have, and how these properties are particularly driven by certain genes in the tumor itself. Over the last few decades, we have numerous medications which are now able to inhibit or target these different genes, which eventually lead to the hallmark of cancer being cancer. And that is really why it is important for us today to understand the genomics, the genetics of each patient's cancer. Here's an example of the strides that we're making in precision oncology and genomic medicine. So this table just summarizes the various tumor types and treatment settings for which precision targeted therapies have been approved. And this is just in 2022. This column here shows the different plethora of targets against which we now have different treatments, which are listed in this column on the right as different treatments. And again, as I said, these are all FDA approvals that have happened in the year 2022. And as you can see, there's a lot of activity in this space, and thankfully, we're seeing a lot of good outcomes with precision oncology in our patients with cancer. So genomic testing and its role in targeted therapy. So as I said, it's important for us to understand the genomics, the genetics of the cancer that our patients present with. And what it is doing is essentially looking at the chromosomes and things at genetic level, which is able to identify the mutation or disease marker for each patient's cancer. And that information is helping us in development of new and more effective treatments for cancer. Here's an example of a typical approach for stage 4 advanced non-small cell lung cancer. So I know Dr. Harada spoke a little bit about different targets that are important in non-small cell lung cancer. And here I'm just listing the 10 different targets and trying to drive home the point that depending on what target we're able to find in the genetics of our patient's cancer, the treatment will be different. So just as an example, if we are finding the EGFR exon 19 deletion or L858R mutation, then we would typically start a patient on osimertinib and contrast that to someone who has an ALK fusion that is detected, where the treatment would be alectinib, brigatinib, or lorlatinib in the first line. So you can really see how much of an impact this has in the decision-making of treatment for cancer that we see on a day-to-day basis in the clinic. And so this is really what has driven this progress in precision and targeted therapies in cancer. So why do we do liquid biopsies? And I think Dr. Harada touched upon this, that obtaining tissue may not be feasible or possible at all times. The tissue can be insufficient, and we still want and need the genomic information for cancer. And that's where liquid biopsy comes in. So small biopsies, cell blocks, tissue specimens, which are not enough to have a genetic test run, it is important for us to do liquid biopsies in these cases. And again, tissue does invariably tend to be the issue for testing oncogene drivers in lung cancer or other tumor types. And so the other thing is, if tissue is inadequate, one can consider a rebiopsy, which is done solely for molecular analysis. But again, there's no guarantee that that will result in adequate tissue, but we will subject our patients to an additional invasive procedure, which we do not want. And that's where the non-invasive, blood liquid biopsy comes in for detection of oncogenic drivers. Here is a snippet which is sort of trying to explain what liquid biopsy brings to the table. In this funnel, really, in terms of access to testing and availability of genomic information, we see that about variably 4 to 40% of patients may not have tissue biopsy being feasible, or may not have adequate samples in about 8 to 26% of patients. And so overall, the failure rate of tissue biopsy can be up to 40, 45%, which is a huge chunk of our patients where we're not able to get genomic information just based on tissue. And again, that's really the role for liquid biopsy. The other role in clinic that I often use liquid biopsies for is that liquid biopsy is easy to obtain. There's not a lot of scheduling issues where you have to schedule a procedure for an interventional radiologist or a pulmonologist to obtain a biopsy, if it's peripheral or a central lesion. The other important area is that the turnaround times for liquid biopsy results are usually faster than tissue biopsy. And that's especially important when we're seeing our patients for our first visit, where it's always good to have that biopsy genomic information to discuss and tailor our discussions to the particular type of treatment we would recommend, compared to a lot of the times when we are sending tissue testing. It typically takes longer, maybe 1 or 2 weeks more. And if we do not have the genomic information at the time of the visit is not as fulfilling for the patients because we don't have a consolidated, solid plan for them. And obviously, all the other things that have been pointed out so far in terms of, this is a non-invasive procedure, easier to obtain. And the other advantage really is this could become a serial biopsy procedure using liquid biopsies as a surveillance strategy or as a strategy to understand whether the treatment is working or not, which is not typically possible with a tissue biopsy. So, with having said all of this, this is really why liquid biopsy has become a very important part of cancer treatment. And so what are we testing? I think Dr. Harada discussed this very elegantly in terms of the different components of the blood we can test for the genomic information using a liquid biopsy, the circulating tumor cells. There is obviously the circulating tumor DNA or cfDNA, but there are also exosomes, platelets, and different other things that are still under research. Today in clinic, the most important and the most useful information comes from the circulating tumor DNA. Again, the techniques discussed were PCR-based techniques or NGS-based techniques. Again, these are what we use in clinic today. In the future, and there's already a lot of ongoing research on other liquid biopsy sources outside of the blood. So as I mentioned, currently we use blood-based circulating tumor DNA testing, but there is ongoing and emerging evidence that potentially there could be different sources of biofluids which we could test for circulating tumor DNA. It could be a cerebrospinal fluid for a patient with brain metastases or brain tumors, a pleural fluid for lung cancer, ascites for metastatic cancers or cancers of gastrointestinal or ovarian origin, stool as well as urine. All of these different biofluids are emerging as potential sources of getting genomic information for the cancer from the free-floating DNA in these fluids. And so the use for liquid biopsy is across different stages. I'm going to first talk about advanced disease, which is typically we talk about locally advanced or metastatic sort of stage 4 cancers. And the applications are obviously, understanding the important genomic markers that are present, which may qualify a patient for targeted therapy. It's also important in understanding primary or secondary resistance and monitoring treatment response, as I mentioned. So if you look at the graph here, you could imagine a scenario where you're starting a patient on a particular treatment and serially monitoring the circulating tumor DNA. If there is good response to the treatment, you would see that circulating tumor DNA percentage decreasing. And as we monitor this serially, we may be able to detect a recurrence of the cancer merely by the circulating tumor DNA initially, which can then subsequently be seen on a CT scan or a PET scan. So it helps us identify potentially resistance or recurrence early than what we conventionally do. Again, this needs to be studied further in well-designed randomized clinical trials, but this is an emerging application, an important application that liquid biopsy offers in advanced disease. The other area where we've seen, sort of in advanced disease in colorectal cancer, we use liquid biopsy, again, to understand the biomarkers the mutations in KRAS, which tend to be very important in selection of therapies for colon cancer, as well as other mutations like HER2, MET, and other fusions, which may qualify or make patients eligible for certain treatments. Here's an example of a particular patient that I treated that has been published actually. And this is a typical utility of liquid biopsy in the clinic. So this is a patient in 2016, initially diagnosed with lung adenocarcinoma, August 2016. Initial EGFR test from the tissue was negative. Subsequently, at progression with PET scan in 2017, identified a liquid biopsy, NGS identified an EGFR mutation, and that's when an afatinib, which is an EGFR tyrosine kinase inhibitor, was started, which then subsequently continued until another mutation, which is the T790M mutation, was identified on NGS in October 2018, which prompted a switch to a different type of EGFR tyrosine kinase inhibitor called osimertinib, which is now first line, but in 2018 was sort of used as a second line treatment. But here you can see that it may not have been possible for us to obtain a tissue biopsy to understand the resistance mechanism. But with NGS, the liquid biopsy NGS, we were able to identify the T790M mutation and start patient on osimertinib appropriately. And then one other thing is that the emerging application of liquid biopsy is also that as we talk about metastatic disease, there is an emerging concept of tumor heterogeneity in the sense that different sites of disease may actually have different genomic makeup. And with liquid biopsy, perhaps we can identify the genomics of the sites which are probably progressing the most, or new resistance mechanisms which are emerging through the heterogeneity of the tumor tissue. So again, this is something that liquid biopsy offers, which tissue biopsy may not, because we will not be able to biopsy each and every site of tumor. But with liquid biopsy, we can understand the dynamics of tumor and heterogeneity across different metastatic sites. In terms of early stage disease, it's very important, an emerging application, or actually something that we already use in clinic today, is testing for liquid biopsy targets for patients that we are considering for neoadjuvant chemotherapy or immunotherapy, as well as adjuvant setting, where we may be able to use liquid biopsy for detection of molecular minimal residual disease, to select patients on who should get further adjuvant treatment after surgery and who should not, or who could probably forgo treatment without much risk of recurrence. Here is a meta-analysis showing for patients with colon cancer, stage 1 to 3, that ctDNA or liquid biopsy is able to identify patients who have an increased risk of recurrence just using the circulating tumor DNA after surgical resection of either stage 1 to 3 disease or even stage 4 disease where there has been local metastatectomy performed. And recently there was a trial that was presented and published subsequently in the New England Journal of Medicine showing that ctDNA-guided adjuvant chemotherapy can perhaps improve our selection of patients for chemotherapy and prevent us giving chemotherapy for all patients, which obviously is associated with side effects and toxicity. So in this particular trial, there was a ctDNA-guided group where ctDNA analysis was used to recommend chemotherapy or not, versus a standard management group where chemotherapy was based on clinical criteria. And what this showed is that the recurrence-free survival at 2 years was similar in both the groups, but obviously less number of patients in ctDNA-guided group actually ended up receiving chemotherapy than the standard management. So again, this can help us identify patients who are higher risk, who may need chemotherapy, at the same time identify patients who are not at a high risk and where we could safely forego chemotherapy and prevent any associated toxicities. Emerging approaches include, testing for minimal residual disease after surgery or chemotherapy and radiation, and trying to escalate or de-escalate treatment for patients in early stage disease. This is yet to be tested in a randomized phase 3 clinical trial, but this is where the field is moving, and we hope that in the future we'll be able to identify patients who need escalation of treatment based on circulating tumor DNA, but also identify patients who we can forego treatments for and prevent toxicities with the therapies that we use today. And then talking more about some of the other emerging roles. Obviously early stage cancer profiling, as I talked about. Also early profiling during diagnostic odyssey, which basically means that if there is a high suspicion for a patient having lung cancer or colon cancer, there is emerging data where patients have potentially had liquid biopsy even before actually getting a tissue biopsy diagnosis, and using the genomic markers that were identified, diagnosis of cancer was made. So again, this is something that's emerging, and I think this will have a huge role and implication in screening for cancer patients, especially for those where there's a high suspicion or high risk. The other things that Dr. Harada spoke about was detection of incidental hematologic pathology like the clonal hematopoiesis of indeterminate potential, as well as detection of incidental germline alterations, which will enable us to identify patients who may have high risk for themselves, but also have familial high risk based on germline alterations, which can be identified again by circulating tumor DNA. And then, as we move forward, the advanced cancer monitoring that I discussed could potentially help and supplement what we do in terms of imaging surveillance today, as well as help us risk stratify based on ctDNA shed, which then can help us escalate or de-escalate therapies. And again, sort of identifying these patients without cancer but are at high risk has a huge implication with liquid biopsy, because this could potentially become an emerging standard as a screening procedure. It can help in early stage with the MRD, post-curative treatment, and as I discussed already, in advanced cancer, it can help determine treatment progression, potentially help determine difference between pseudo-progression and true progression for patients on immunotherapies. And again, these are all things that are emerging and increasing applicability of liquid biopsy in the clinic. And so this sort of summarizes these roles across the spectrum of cancer treatment. So as you see in screening, early stages when post-surgery for minimal residual disease, in follow-up surveillance for patients who have already had surgical resection of cancer and trying to risk stratify or predict recurrence of cancer, in stages where there is relapse to identify genomic markers for cancer treatment in advanced setting, as well as identifying acquired resistance and emergence of driver and resistant clones using ctDNA, like the example I showed you for the T790M mutation in an EGFR positive non-small cell lung cancer patient. And so this is another example of liquid biopsy in the clinic. So a 69-year-old woman, never smoker with a diagnosis of stage 4 lung adenocarcinoma, underwent NGS liquid biopsy, which demonstrated a ROS fusion. And then based on that, we initiated crizotinib, which is approved for this particular genomic marker for lung cancer. And you can say that see that there is a clinical and radiological improvement. So on the left is the scan at baseline. You can see different areas of the lung lighting up, as well as the couple of lesions in the liver. And then you see that after patient was started on crizotinib, there is improvement with almost complete response on this right panel of images that are shown from the PET scan. This also led to quality of life improvement. So the performance status that we measure for patients we are starting chemotherapy or treatments on, you see that the performance status improved from a 2 to a 0, which actually is that patient was fully functional after the resolution of the lesions with the treatment. And this is really kind of exemplifying the importance and the role of liquid biopsy in clinic today. And so in conclusion, genomic testing plays an important role in targeted therapy of cancer. Liquid biopsy offers a unique opportunity to understand these genomic markers and has applications across advanced disease, emerging and evolving roles in early stage disease. There is obviously things in colon cancer which have been shown in clinical trials, emerging role in other disease states like lung cancer, breast cancer, and others. There is emerging role in cancer screening, risk stratification, and surveillance. And finally, as we saw, liquid biopsy forms an important component of biomarker testing in clinic, informing treatment decisions today. Thank you.
Thank you, Dr. Harada and Dr. Desai, for your presentations. They were very informative and well presented. So now we're going to move to the Q&A session. And just a reminder to all attendees, if you have any questions, please insert them into the Q&A box on the right side of your screen. I have a couple of questions I'd like to start with. So what is the role of liquid biopsy in clinic today for early stage cancers?
Yeah, so I think as I discussed, I mean, depending on the cancer subtype, we are already utilizing liquid biopsy in early stage setting. So as I showed for one of the, for colon cancers, there is a trial to identify patients who need adjuvant treatment, meaning treatment after surgery with chemotherapy. There are trials that are currently ongoing for lung cancer and breast cancer to, again, utilize this to inform our decision-making on patients who may or may not need treatment to prevent recurrence of the cancer down the road. So I think it's an emerging and evolving field, especially in early stage lung cancers. There's obviously recognized benefit with colon cancers with that trial that I showed you, and things are sort of coming down the pike in other tumor types as well.
Great, thank you. Another question, what are the major barriers in application of liquid biopsy today?
I think in the clinic, from a clinical perspective, I think one of the major barriers is, these are largely done as a third-party sort of different platforms. So I think as a clinician, sometimes it becomes difficult to understand the nuances, again, which Dr. Harada explained really nicely, to understand the nuances between different platforms that are available. And I think the applicability and the importance of this testing and how to apply and interpret the test results, I think can be and is challenging. I think there has been studies that are showing that even when tests are being ordered, oncologists may not be prescribing the right treatment for the right genomic marker. I think these reports are now getting better in the sense that, most of these companies that who do the liquid biopsy testing are now in their reports putting what treatments are FDA approved for this genomic marker and what clinical trials are available, which again is an important piece of precision medicine, precision oncology. I think the other barrier may be that there is a cost of doing this liquid biopsy. Obviously, these are emerging technologies, and so there is an associated cost. And to be very honest, I think we don't truly know the implications of this as a financial standpoint to the patient, because a lot of the time, some of this is covered. Some of the companies offer patient assistance programs, but it's very individualized, and we typically don't think about it until these things come up from our patients, because we hope that these are covered. But I think we need more information and more data on whether this is having a significant financial implication on our patients today. Because as we think about doing these more often and more serially, I think this will become important to understand how this impacts financially in terms of the chronicity of these tests.
Great, thank you very much. Dr. Harada, a question for you. What is the cause of false negatives?
Yeah, there are a lot of causes because, the biggest problem is negative doesn't mean rule out the really no mutations in the liquid biopsy. And one is, of course, sample handling. If your sample is vastly diluted by genomic DNA, it is hard to detect the uh, mutation pattern. And also, there's a tumor. Depends on the tumor. There's some of the tumor may not be shedding a lot of tumor DNAs into the bloodstream. So it really maybe sometimes you may not be able to detect. Also, the sample handling as well. That's what I already said. I think that's a major cause of the reason to be false negative, which always need to interpret with caution for that.
Yeah, I think that's an excellent point. I think we face this in the clinic quite a bit, where we order a test, liquid biopsy test, and you don't find any particular genomic marker which you can use targeted therapy on.
Mhm.
I make it a point to say when I'm documenting this that no alteration was detected. That does not mean it was negative, meaning that the patient's tumor can still have a genomic driver which may have a targeted therapy. And so I think one thing which I would like to emphasize is, like, for those tests, we still tissue biopsy and tissue testing is still the gold standard. And so if you find nothing in tissue and nothing in liquid, then we say, okay, there's nothing that we can target today. But if you find nothing in liquid, that does not mean that tissue will not be able to find a genomic marker which you can target. So I think that's a very important point. And that's why, I mean, if it's a false negative, I tend to say that no alterations detected, because again, you could have those alterations detected in the bloodstream as in when there's tumor progression and there's enough ctDNA shed, to Dr. Harada's point.
Yeah, totally agree with you. Yeah, definitely. If you have both tissue and blood liquid, that would be the best scenario we can compare and then monitor. But unfortunately, that's not always the case.
Yeah, and then another alternative scenario is where you find something in the liquid biopsy, let's say, for example, an EGFR mutation against which you can use osimertinib, but you don't find that in the tissue biopsy.
Yeah.
In those kind of scenarios, I think most of us tend to take the liquid biopsy result and go with the targeted treatment, just based on the fact, because you have to understand with the tissue, I mean, it all depends on the part of the area that was biopsied and whether that had the genomic marker or not.
Right.
Sometimes the sample is inadequate, or you don't have a huge confidence. There could be different, and as I mentioned, there could be different metastatic lesions. And with the tissue tumor heterogeneity, you tend to think maybe there's a component of EGFR coming from a site which wasn't biopsied with tissue. So I think we would take it as a positive if it was on the liquid and not on the tissue, but it doesn't mean that if it was negative, you don't look at the tissue.
Yeah. Yeah, that is a good point. Definitely, tumor heterogeneity counts on a large part. Also, sometimes tissue may not have enough tumor cells, a lot of stroma cells or inflammatory cells. And so that tissue biopsy can also cause false negative if the tumor cells only count on like less than 10% of the tissue nuclei tested.
Absolutely.
It's a great discussion. Thank you both. I think that's about it for questions. So I'd just like to close out by saying thanks so much to Dr. Harada and Dr. Desai. A massive thank you for being with us today and presenting on this topic. And thank you to all of you who have taken the time to attend and digest this presentation. Please be sure to register or log into DXRX and check out our library of previous lab talks, as well as the ability to stay up to date with upcoming opportunities. I look forward to seeing you at future events, and I hope you have a great rest of your day. Thank you for tuning in today. Goodbye.
Thank you.
Thank you.